important messages of this meeting down the line. I think this meeting is significantly inadequate only in that respect that we need more people where these patients first present. And I would look at pediatricians and respiratory physicians, general pediatricians and respiratory physicians that fall in a very high category there. So at least we know when we organize our meetings whom to call now and get these messages across. So a little bit of overlap from yesterday, but today's talk will be short. We will be reaching the end of day 2 and follow these 5 points. When you comprehensively manage sleep apnea, and I know many of you all are surgeons here, remember that the delay to first recognition is as long as 87 months on an average. And I think you saw from the Singapore General Hospital talk, the oration this afternoon, that if we have to move ahead in this branch, you have to not just be working as a team, but you've got to get ahead of the game. You've got to get onto a diagnosis much earlier. You'll be doing much more. And only 4% of these references were made by a good sleep history. Can you imagine? So sleep histories were just not being taken. Once the OSA features become available, again the time to testing is another 8 months. And the lack of reporting and the lack of obtaining a good history contributes to so many of these delays. So if we're going to have delays in diagnosis of OSA, we're going to have a lot of problems. So that's the first thing to tackle if we have to manage this disease comprehensively. In a sleep history, and I know surgeons do not take history sometimes as long as physicians, or maybe they do, I would stand corrected, but I think taking a good sleep history was something we were never taught in medical college, neither undergraduate, and you'll be surprised even when I finished post-graduation in '91, I was not taught how to take a good sleep history. Asking about insomnia, especially difficulty in initiating sleep or maintaining sleep, both are important because both have different ways of management by a good psychologist. We don't ask about it, and many sleep apneics are actually insomnic, and we think, okay, they don't have excess daytime sleepiness, this can't be sleep apnea. Not at all. So please remember, a lot of these patients are insomnic. What is the reported snoring, choking episodes, agitated arousals, and their daytime symptoms? Are they refreshed or not? Are they fatigued? Are they tired? And so this will give you a fair idea, and this really all boils down to the Berlin questionnaire, but don't go by scores very strongly. One of the best scores is the Stop-Bang score, which I'll come to. And whenever you see a relative, a friend, or a patient with 3 or more than 3 blood pressure medication, you will be surprised how many of these patients have a sleep apnea undiagnosed. Ischemic heart, atrial fibrillation, diabetics, and we learnt again, which I added after I heard the oration, normal tension glaucoma, lung cancer, and we have so many malignancies, not just head, face, neck, which have comorbid sleep apnea, and that gets set aside sometimes in the management as, okay, we'll think about the sleep study later because we are anyway waking up in the morning. Let's deal with the cancer first, without realizing that the quality of life can change so much with management of sleep apnea in contrast to sometimes the drugs they have to receive for cancer. CKD, talk to your nephrology colleagues. You'll be surprised how many referrals I get from nephrology colleagues where the creatinine is going up because 3 or more drugs for hypertension means the load on the kidney is increasing. So that creatinine inching up to 1.3, 1.4 is itself a danger sign. A good nephrologist will pick this up pretty fast. And those patients who are on dialysis, the incidence is even higher. And of course, depression and excess daytime sleepiness. So there's a whole group of specialists that need to be made more aware of this. And if you have people in these specialties who are aware, those are the people to talk to and tell them about what can be done besides positive airway pressure. I've added pediatricians after seeing the amount of pediatric dental orthodontic work that is happening in this space. This is Stop-Bang. You don't need the slide, it's available on the internet, but it's a great questionnaire. And as far as the need for the study is concerned, I think I alluded to this yesterday, diabetes control, hypertension control, the afterload and the oxygen demand of the heart both go up. And when I tell this to my patients, they get worried because they know their heart is ticking, but they don't realize the load on their heart. It's just like chronic lung disease has very often ambulatory hypoxemia. That means they walk, they drop their oxygen. And that's the time we tell them to buy a portable oxygen concentrator and walk with their oxygen. So hook it on, put the oxygen on, walk. They're 94-95% at rest. And then they say, we'll use oxygen once or twice a day sitting watching television, and obviously that's of no use at all. When they need it, they need to use the oxygen, which is during exercise, physiotherapy, ambulation. The same applies to sleep. They need that oxygen in the bedroom while they're sleeping, and that is not going to be given with oxygen, that's going to be given with positive airway pressure or opening that upper airway. So talk to them about this, and we often reassure them that it's all about getting your upper airway more patent. Memory loss, cognitive decline, and you'll find an elderly patient who's being treated for Alzheimer's, undergoing MRIs, tests, and someone's just forgotten the fact about the quality of his sleep. Thankfully, that is reducing nowadays, and of course, work hazards is so obvious, road traffic accidents, work output. So there are a lot of reasons why you should tell patients that they need a study. And of course, as I explained yesterday, the load on the heart is a double whammy. It's the hypoxia, which is reducing oxygen supply to the heart, and then the sympathetic activation, which causes vasoconstriction and increases that afterload. So both ways, the cardiovascular system is hugely affected. Coming to communication and convincing a patient. As I always say, sometimes you have the most competent doctors around, and I'm sure you all have had colleagues very competent, but failure to communicate can really create a problem. And likewise, you can have people who are great communicators but are not competent, and then you have the other end of the problem. They have the gift of the gab, but they don't know what to do. And so understanding communication means understanding the barriers, and I went through these yesterday: ignorance, denial, elaborate tests, the treatment, the costs, compliance, and the size of the machine. It's like an inhaler for asthma is more daunting than a tablet. Yet the patient prefers the tablet for the simple reason he doesn't understand the dose in the inhaler is about 100 times less than the tablet. So these kind of barriers have to be overcome with communication. And patients remain in denial because they just don't like to face reality. They try to buy time on this, they feel vulnerable. And the biggest ignorance here is actually among chest physicians and patients themselves. So I blame a lot of respiratory physicians for being unaware of how common sleep apnea is in their patient population. And they have to think of it. It's a critical part of the respiratory history. And this ignorance, if in a respiratory physician, is going to transcend into ignorance by our patients. So I think this group needs to talk more to the respiratory group. And you'd be surprised how little respiratory physicians know about 70 to 80% of what is being discussed in this meeting. So this denial on the part of the respiratory, his life is going on, right? His practice is going on. There's enough work in respiratory medicine for people to now bother about having a conversation on the quality of the patient's sleep. So what do you do with denial? I think you need to make the patient or the parent understand. And if they don't understand, they're never going to accept doing a test. If they don't understand why they need a test, and I'm sure many of you all are good at explaining why a surgery is required, but please remember, surgery is an interventional procedure, and that does scare anyone, including physicians. Understanding solves a lot of this problem. And so I would encourage you to make patients understand it applies to any disease I manage, whether it's asthma, interstitial lung fibrosis, which is my area of interest, COPD, any disease. The patient understands, the patient suddenly starts talking a different language with you. And if the patient is incompetent, then you have to escalate to a responsible authority in the family, hoping they will not shield further. and understand whether that problem is affecting the patient's work, especially when it's dealing with human lives, like in public transport. And as I said yesterday, even in the Q&A session, address mask, pressure, and nasal issues. All three are important. And how do you deal with these? With the mask options, you have full face, you have nasal masks, and you have nasal pillows. All three can be options, and when you do a titration study or a split night study, keep all these options available so that you don't have to run back for another mask. Artificial intelligence, I understand, is going to change this whole scenario, and you'll hear more about that in other talks where you can make out what will suit a particular patient. If it's a pressure issue, use auto CPAP. Alcohol, sedatives is going to change the pressure requirements. Someone goes and binge drinks, the pressure requirements will go up like anything that night. Classically, the sleeping partner will tell you that the moment my husband consumes alcohol, he's snoring much more. And so all this will need a little variation in pressure, and auto CPAP solves that. He tosses and turns too often. He's planning a drastic weight loss. You can't keep doing titration studies, so just prescribe auto CPAP. And especially if they need more than 10 centimeter water pressure or just before bariatric surgery, auto CPAP. And then you have the nasal issues, which is extremely important, and the nose is not just what respiratory physicians see. And I think the future is going to see a lot of ENT surgeons subspecializing in rhinology. And I wouldn't be surprised about this, because rhinology is such an important branch when it comes to sleep medicine that it sort of goes hand in hand. And nasal steroids, of course, is what we offer our patients, but there's much more to the nose than treating it with nasal steroids. Studies, I did discuss yesterday, overnight oximetry and apnea link is very much screening tests. Apnea link simple to attach, but the full PSG is far more useful. You get latency, how long it took the patient to sleep. As you know, sleep latency should be less than 20 minutes. And REM latency, how long did it take them to go into REM sleep, which takes about 80 minutes. And if you see someone getting into REM sleep in less than 10 minutes, you know this is probably narcolepsy, and that's something you should pick up. Desaturation during REM or non-REM, and you can move to a split night if the AHI is more than 20. Titration, does PAP correct the sleep apnea? Does the interface tolerate? Has sleep efficiency improved? So there's so much information on titration that I would recommend every patient should undergo it ideally, and you can tell the patient what PAP has done to them. And finally, the last 2 points, insomnia. Please remember, as respiratory physicians, we sometimes call ourselves sleep specialists. Many of you all will be calling yourselves sleep specialists. So remember, you're suddenly going to have that patient entering your clinic saying, I'm insomnic. And that's not easy to manage, trust me. Insomnia is much more common than OSA symptoms sometimes, and the management basics need to be clear. Patients can present with insomnia. 3 things you should always remember. Sleep hygiene, keep a sheet, a handout with you, it's available on the internet. Get a good psychologist or learn cognitive behavioral therapy yourselves. There are courses on it. And if both those don't help, only use a drug. The only other time I use a drug is when I need my patient to tolerate CPAP the first week or 10 days, and sometimes I prescribe a drug if they are anxious or intolerant to CPAP. And finally, when you treat these patients and comprehensively treat them, you have the mild to moderate OSA patients where weight reduction, positional therapy, and I can tell you most chest physicians would say weight reduction, positional therapy, maybe a mandibular device. This is all I knew, and I'll be very honest before this meeting. I put surgical evaluation right there on top for mild to moderate OSA. We need to understand this better. We need to get this done. Severe OSA, of course, nasal or oronasal PAP is a great treatment, but not always, and you patients want a cure. And bilevel PAP, when they're morbidly obese, the PCO2 is more than 55, associated COPD, or they just cannot tolerate CPAP. Surgery, again, to be evaluated because patients want to get off CPAP. What is the conversation you have? So check these things on follow-up. Quality sleep, weight reduction, comorbidities, and discuss the pros and cons of surgery, especially if CPAP has helped. Do not fail to evaluate. Find your buddy, ENT surgeon, max fax person, orthodontist, and work as a team. So to conclude, sleep history, communicate well, be clear on the studies. That's very, very important for any person who calls themselves a sleep specialist. Find your respiratory physician who has interest, find your pediatrician who has interest, and show them what they're missing in the upper airway. That's what they're going to learn from you. And I cannot underemphasize this. And get into general pulmonology and pediatric meetings as a lateral topic. Patients like a break from the monotony of what they're listening to. Finally, this is how pulmonologists are managing OSA 2023, just for you to get a snapshot. A home study, unsupervised. They're told to buy CPAP or lose weight. They're given only two options. If they're intolerant to CPAP, they're prescribed bi-level PAP. And if they're tolerant, that's a success story. And they've forgotten about the patient has forgotten about the doctor. There is little or no follow-up. And this is happening in, I would say, conservatively 70 to 80% of patients that come to only a pulmonologist, which is really sad. All PAP, all that is there is PAP. What is expected of pulmonologists and what we expect, hopefully in 2023, and hopefully we kick it off this year, because maybe this is the first time I'm attending this meeting, but I'm sure Srinivas has called pulmonologists before, but I would like this to happen, a detailed history, more time. As Jeevanan said, he spends 1 hour with his patient, first consult. With my ILD patients, I spend 45 minutes to an hour. First consult. With my sleep study patients, I think I will have to now. Since I'm wondering what I'm supposed to call myself, ILD and sleep specialist. Explain the sleep study to the patient and the parent. We don't explain it. You will be surprised, 80% of reports I see that come to me for a second opinion are unsigned reports, computer generated. Explain all options. There's no dearth of options for the patient today. And listen to CPAP tolerability. Whether it's good or poor, good doesn't mean the story has ended. Close follow-up conversations, because now, when you have that conversation, you have not just increased your interest in getting the patient rid of the problem, but the patient's interest towards a possible cure. Thank you very much. Thank you. Thank you.